Hello, I'm Curtis Crane from the Crane Center of Transgender Surgery. I'm a board-certified plastic surgeon and a fellowship-trained reconstructive urologist. And today we're doing a Facebook Live session for you on non-binary surgical options. I've had many questions submitted from patients, and I'll go through these. As I go through these, feel free to send in questions in the comments section on the Facebook page, and we'll get to as many questions as we can. So first question that I have is, what does non-binary mean? I have an engineering background, and so when I think of binary, I immediately think of binary code, which is zeros or ones. When it comes to gender, binary typically means male or female. So non-binary is a term used to say you don't believe there is just male or there is just female. There's a continuum between male and female. What does non-binary surgical options does Crane Center offer? We offer everything you can think of. I opened this practice 8 years ago. I've seen at this point thousands of patients from the community, and I can't think of a time that a patient has come up with a surgical request that I haven't been able to fulfill. And I believe that's because I'm one of the only ones in the world that's a plastic surgeon, did a fellowship in transgender surgery, a urologist, and did a fellowship in reconstructive urology. So with having the armamentarium of both a plastic surgeon and a reconstructive urologist, I really can come up with sort of any reasonable surgery that a patient asks for. In the beginning of my practice, within the first year, I'd say, I had a trans man come to me, and he wanted a phalloplasty, but he wanted to keep his vagina. And I said, well, no problem. I've never been asked to do this, and there's certainly not anything published on it, and I've never seen it, but I'm happy to think about this for you. And so I went home, and as always, I go on a run, and I do some soul searching, and I think, well, is this okay? I think is the first question. And I quickly came to the conclusion, yes, it is. Being a trans man or trans woman or non-binary, it has nothing to do with your anatomy. It has nothing to do with what's between your legs. There are plenty of non-binary, gender fluid, genderqueer, trans patients that don't get any surgery. And it doesn't make a man any less of a trans man if he chooses never to have phalloplasty and never get a vaginectomy. So I quickly thought, yeah, that's fine. And then I also came to the conclusion that gender does exist on a continuum. That's what the community has taught me. And so if gender exists on a continuum, why then would my surgical treatments be binary? That doesn't make any sense, to recognize gender exists on a continuum, but I'm only going to offer all male options or all female options. And then lastly, I didn't ask, but I assume he wanted to keep his vagina. He already had a hysterectomy. I assume he wanted to keep his vagina because he got sexual gratification out of having a vagina. And I thought, it's kind of assault to make a patient remove an organ that they're enjoying. Let's keep it. So I came up with a surgery where we performed a phalloplasty and kept the vagina. That was one of the first sort of non-binary surgeries I've done, and since then, I don't know how many I've done, hundreds. Do I have to have a hysterectomy to have bottom surgery? No, you don't. The only time a patient has to have a hysterectomy is if they want a vaginectomy. The uterus secretes stuff. It's a secretory organ, and that fluid needs a way out. Whether it's serous fluid, blood from a menstrual cycle, anything, it needs a way out, or else the fluid builds up. The uterus doesn't know the vagina is gone. The fluid builds up and it causes discomfort. So the only person that needs a vaginectomy, the only person that needs a hysterectomy is if the person wants a vaginectomy. And as many of you know, it's fine to have a hysterectomy but leave one or both ovaries. That's no problem. Another question, can I have both a vagina and a penis? If so, how does that work? I've done that surgery. A few years ago, I had a college-age student that was born with male anatomy, and she said that she identified as female, always wanted a vagina, but got sexual gratification from her phallus and did not want to have to sit to urinate. And so I said, okay, normally when we do a penile inversion vaginoplasty, we use the penile skin to create the vagina, and if there's not enough penile skin, sometimes at the very top we do a scrotal skin graft. So I said, we won't have that skin to use, but if you don't mind me giving you a small tummy tuck scar, I can harvest full thickness skin graft from there and create a vagina. And so she said, okay, and we did the surgery, and she healed great. Everything went really well, and that was a few years ago. I haven't heard any complaints. So that's another example of how here at the Crane Center we're willing to recognize this is your body, these are your needs, and one of the reasons why I did so much training in 2 different surgical subspecialties is so that I could create safe surgeries for patients that don't have standard requests. Is there an increased risk of complications if choosing to have both a vagina and a penis? What are they? In the example I just gave, I've done a few of those and I haven't seen a major complication. The area where there is an increased risk of complication is with urethral lengthening for a patient that was born with female anatomy but wants to go some degree towards male anatomy. The issue is when you perform a vaginectomy and then the next step is to lengthen the urethra, you use labium, or I use labium minora flaps, and if there's a vaginectomy, there's a lot of layers of skin to close over where the urethra makes a 90-degree turn. Female anatomy, the urethra's here, and then it stops. Male anatomy makes a 90-degree turn and then comes out to the tip of the phallus. Right at that point where the urethra makes a 90-degree turn, I love closing multiple suture lines over there, so that over that spot, so that a fistula doesn't form. A fistula is a connection from inside the urethra to the outside skin. It's when 2 suture lines heal together that you don't want to heal together, meaning I build a urethra over here, I want it to heal as a tube, and then out here is the perineum or the outer surface of the patient's skin. And you don't want these 2 to heal together because then urine can come out here. But that's what a fistula is. They sort of heal together. So if I'm doing a vaginectomy, I can have a lot of tissue. Like, to me, that's a lot of tissue to close over that 90-degree turn. If you don't do a vaginectomy, you just have a few very thin vaginal mucosa flaps to close over that area. So we did a study, and there's about a 40% increased risk of getting a fistula at that 90-degree turn if someone doesn't want a vaginectomy. However, this is usually in the case of phalloplasty or it may be meta. Fistulas can happen. I did a year fellowship in repairing fistulas. They don't scare me. I often tell my Fallow patients, hey, look, if you get a stricture or a fistula, which is the most common complication, it's like it's a relatively minor revision. If you view your phalloplasty as a Ferrari, we just built you from scratch. A fistula or a stricture repair, it's another surgery, it's another 2 weeks with a suprapubic tube, but it's like changing a tire out on your Ferrari. it doesn't mean you've totaled the Ferrari. So I always have this discussion with my patients that want urethral lengthening but don't want a vaginectomy. And I always finish it with, if having the vagina is important to you, we should go for it. Just understand there's a high chance that you'll need another surgery to repair that fistula. And then fortunately, almost every fistula repair I've done has worked. I have about a 95 to 98% success rate with the fistula repair. And then the patient has a vagina, has the urethral lengthening, and they're happy. Is there an increased risk? Oh, I'm sorry, I just did that one. If I add Fallow and keep my vagina, how is the surgery different than normal phalloplasty? I invented a way where I create some vaginal flaps and kind of advance them over that area where the urethra comes straight down, and then we start the urethral lengthening. So I swing a few flaps over to help buttress that area and prevent the risk of fistula. And that's really the only difference. But then after that we finish the urethral lengthening, build the scrotum the same way, and perform the phalloplasty. Will I have sexual sensation in my phallus if I keep my vagina? Absolutely. When we do a nerve anastomosis from the skin of the phallus, we do that to the clitoral nerve under an operating microscope. So there's multiple nerves across the clitoris, two main ones, and we take one of those, hook it up to the nerve from the flap, and then the nerve, after 9 months, it grows about 1 millimeter a day, grows down the myelin sheath of the nerve in the flap. If someone doesn't want a vaginectomy, the nerves around the vagina are totally different from the nerves that we use to give sensation to the phallus. None of those vaginal nerves are cut, and so it is no problem to have sensation in the phallus and keep sensation in the vagina. Next question. If I want to keep my penis and add a vagina, how is this accomplished? What is the vagina built out of, and will it have sexual sensation? We kind of covered this a little bit earlier when I described my patient that did not want her phallus removed and did not want to sit to urinate. I built the vagina out of full thickness skin grafts from the lower abdomen. It kind of gave it a tummy tuck so that if she wanted, she could wear a low-cut swimsuit and have her scar not show. So the vagina is built out of full thickness skin graft. I believe the patient had sexual sensation because the prostate is never removed in any of these surgeries, and the prostate some regard as the male G-spot, and when palpated can give sexual satisfaction. And then obviously all sensation in the phallus would be maintained. The next question, what is a nullo? And how do you achieve this? Nullo is not a medical term. It's a term created by the community that's short for nullification. And it's typically someone that was born male that doesn't identify with their penis, testicle, scrotum, and so they want that removed, the urethra rerouted to the female position, they sit to urinate. We do these surgeries ethically. I think it's perfectly reasonable. We achieve this. It's similar to a vaginoplasty, except we don't create a clitoris. We don't create labia minora and majora. We don't create a vaginal canal, but we do disassemble the phallus the same way we do in a vaginectomy, and then I shorten the urethra and we place that in the anatomic female position so that the patient can sit to urinate hygienically. The next question, I identify as non-binary. Can I still have top and bottom surgery? Yes, absolutely. This is no problem. As I mentioned, I've had many non-binary patients want vaginoplasty, phalloplasty, something in between, metoidioplasty. It's no problem. Top surgery, like I said, whatever a patient's request is, whether they just want more of a breast reduction, or if they want to be completely flat, or if they want to be completely flat with no nipples, or if they want nipples in the shape of a Christmas tree or the Star of David, we're happy to accommodate your needs. Let's see. I have a question here. Do you have cases where you need to use biologic graft materials for repair of fistula at the neourethral anastomosis? And if so, how many cases? So that's a great question. Biologic grafts are really common. I've worked with Stratus and Alloderm a lot. I've done a lot of cleft lip and palate where there was a fistula in the palate and we put a little piece of Alloderm or really some other biologic to cover the fistula. When I started doing these cases, it was like such an endeavor to get insurance companies to pay for it. And so then when you start asking for biologic grafts, I thought they would really lose their shit. So I thought, well, I have a patient that could use a little biologic graft. What should I do? Well, Alloderm and Stratus, it's dermis from a cadaver, and we are each a storehouse of our own living human dermis that doesn't have to come from a cadaver, which kind of freaks some people out. So I've done a number of fistula repairs where, just to get more coverage, I'll harvest some full thickness skin graft, close it in a pencil thin line, trim off the epidermis, that's the skin part, and then use the dermis below, same as they use in Stratus and Alloderm, to buttress the fistula repair. I can't remember anyone showing me that. I think I made it up, and it works, and you don't have to pay for the Alloderm and the Stratus. So if it's a cash pay patient, it's free. If it's an insurance company, you're welcome. Please cover more surgeries. And so how many times have I done this? I bet more than 100. It's something I used to do on every patient, and now I do it if I'm concerned that the fistula repair might break down. Great question. Let's see, another question. I don't identify as transgender or non-binary, but rather gender non-conforming. Can I have surgery? Absolutely. The terms non-binary, gender non-conforming, genderqueer, gender fluid, they describe a patient's experience. And they all have differences between the two, but when it comes to submitting codes to an insurance company, they want a diagnosis code. And even though the term is gender incongruence is the diagnosis code, that can describe whether it's accurate or not, gender nonconforming, gender fluid, gender queer. It's really the only code insurance companies have. Like, I'm really impressed insurance companies have come around to the point that we're able to submit a diagnosis of gender incongruence, and that's getting covered more and more. In my practice, about 85-90% of our procedures are covered by insurance, which I'm very proud of. We worked really hard to get to that point. So having crossed that bridge where a lot of insurance companies are covering this, I'm hesitant to go, you need to change your diagnosis codes and also include these other diagnoses, because I feel like they can sort of barely handle what's going on now. I mean, it used to be in 2013, 14, probably even 15, I do a vaginectomy on a trans man, and we get a letter from the insurance company, code denied. The patient is listed as male, and vaginectomy is a female procedure. You'd say, yeah, that's very astute of you. The patient's trans and needs a vaginectomy, and it was often we'd get a response back. Yeah, the computer won't allow that. I'm like, well, train your computer, because we've progressed as a society. So point is, I'm super stoked now that less and less I'm getting these denials for doing a vaginectomy on a trans man. I have not yet pushed the front of saying you need a separate non-binary or gender non-conforming code. So we often just submit the diagnosis as gender incongruence, and hopefully that's not offensive to patients. That's never our point. We just don't want to confuse insurance companies, and we want to get your surgery covered. The next question, will insurance still cover my surgery if I don't consider myself transgender? I kind of just went over that. We just submit the codes as gender incongruence and keep our fingers crossed. Once insurance companies sort of progress to the point that there's more diagnoses codes, then we can be more accurate. Is there a difference between top surgery for non-binary folks versus trans folks? Not really. A patient comes in my office, and I think it's very important as a healthcare provider for this community to say, what are your pronoun preferences? How can we address you respectfully? But then at that point, I don't categorize a patient in my head as genderqueer, gender fluid, non-binary, gender non-conforming, or transgender. They're just someone that I want to help. And so whether you see yourself as any of those, I respect that, and we'll use appropriate pronouns. However, when it comes down to just talking surgery, you're a human being. Most humans have pretty similar anatomy to each other, and together we come up with a surgery that meets your surgical goals. Let's see. Can you speak to surgical regret? It is something I hear a lot about, but doesn't seem backed by much literature. Fortunately, I actually can't totally speak to that. I can't think of a patient that regretted their transition in my practice. Dr. Brownstein, our practice used to be called Brownstein and Crane Surgical Services. I took over Dr. Brownstein's practice. He did top surgery only for the community for 35 years, and he estimates he did 7,000 surgeries, and he knew of 2 patients out of 7,000 that regretted the surgery and then went back and got breast augmentation. I've probably seen 2,000 patients in 8 years, and I can't think of a patient that's regretted surgery. So fortunately, I have no experience with that. Sorry, I can't answer your question. Next question. Do I need mental health referral letters if I don't identify as transgender, but I want surgery? This comes down to who's footing the bill. If you're a cash pay patient, we don't have to go by insurance rules, and I take each case by case scenario and consider it. I've had many patients where they say, hey, look, I grew up in a small town in Kentucky. Not to pick on Kentucky, I think Kentucky's great, but let's just throw out a state. And there is not a therapist in my town that would understand my situation enough to write me a letter. I would have to make an appointment with one, teach them about what it is so that they could write me a letter saying that this is the next best step. I've been on testosterone for however many years, and I've lived as my true gender for however long. And so in situations like that, if it's a cash pay patient, I say, yeah, let's waive your letter. I deem this appropriate, and I understand. Let's not have your letter. If the insurance companies are footing the bill, we have to play by their rules, and they always want 1 letter for top, 2, sometimes 3 letters for bottom surgery. And I have never seen an insurance company say, yeah, you're right, Dr. Crane. Even though, you're a world-renowned expert in this, let's go with your professional opinion instead of, our employees that know nothing about it. Unfortunately, that doesn't happen. So we have to play by their rules. If they want it, then we get it. Next question. Am I able to keep my reproductive organs with non-binary surgical options? Yes, absolutely. There are some patients that the most common scenario is a patient that's pursuing phalloplasty or meta. They may have already had a hysterectomy, may want a vaginectomy, and they choose to keep an ovary so that their eggs can be harvested and they can have their own offspring. That's certainly no problem for anyone. Next question, if I choose a meta, can I keep my vaginal opening? Definitely. This goes back to the discussion that I had maybe 15 minutes ago regarding urethral lengthening while keeping the vaginectomy. There's a higher risk of fistula right where the urethra comes down, and I start the urethral lengthening at that 90-degree bend. There's a higher risk of fistula right there, probably around 40%, but it's no problem. Now, if you're wanting to pursue a meta, but you don't want urethral lengthening, and you just want the urethra to stay right where it is, there's absolutely no risk in doing the vaginectomy. Do I need to be on hormones to have surgery? No, you don't. This used to be a requirement for top surgery, but we have many non-binary patients that say, I didn't like the way I felt on testosterone. But I still don't identify with a female chest. And so it's no problem. It won't change the surgery at all. You can get the exact same result. And a patient no longer has to be on hormones. For bottom surgery, it is still a insurance requirement to be on hormones. So again, if the insurance company's footing the bill, we got to play by their rules. If you're cash pay, we can do whatever we want within reason. Do I need a hormone letter explaining why I'm not on hormones? I think if an insurance company required a letter and a patient, for example, didn't want the cardiovascular risks of being on estrogen, or they had some other contraindication to being on estrogen or testosterone, then a letter stating that would probably help. The authorization would probably get denied, and then we do an appeal and a peer-to-peer review, and then I would explain to a doctor from the insurance company, this is why the patient doesn't want hormones, and in my world-renowned expert opinion, that's okay. The next question, if I'm not on hormones but want top surgery, will my breasts grow back? No, not necessarily. The only time I've seen breasts grow back is if a patient, say, gains more than 30 or 40 pounds. You have to leave some amount of fat along the chest. If you remove everything, then the chest gets a kind of a sunken appearance. And so this is not a surgery for cancer. Our goal isn't to remove 100% of breast tissue cells or fat. The goal is to give an aesthetic appearance, a nice contour. And so some fat is left. When patients gain weight, the fat cells, you don't get more fat cells, just the ones you have get bigger. And so you can certainly eat through your top surgery, but I think it would take at least 30 or 40 pound weight gain. Next question. If I get phalloplasty, where does my clitoris go? I would love to put the clitoris all the way out to the head of the phallus. That would be great for purposes of sensation. However, it never stretches that far. So I put it out as far into the phallus as possible, and usually that's somewhere along the base. That's as long as the clitoral nerves are. Can my clitoris be buried or exposed? Yes, it can be either buried or exposed. 99% of my patients choose for it to be buried. Aesthetically, it's felt that most patients feel that that looks better. Even though we bury the clitoris, there's still a very erogenous area there with sensation. And so that's typically the way to go. But yes, you can have it buried or exposed. Next question. Do you work with removing the uterus and transplanting it to a person who is born without one? No. I have never specialized in transplant surgery. I thought that I'd stop my residencies and fellowships after 11 years and enter the workforce before I was eligible for Medicare. No, that's next level stuff. I know there was a trial in Scandinavian countries, not with patients in the community, but with, I believe it was Meyer Rakutansky, people born without vaginas, uteruses, and they transplanted uteruses. Patients got pregnant, they gave birth. I have not done that. I don't think I have the expertise to. You need to do a transplant fellowship. And in addition to that, I don't think insurance companies would pay for that. We are really happy when insurance companies pay for vaginoplasty and breast augmentation and facial feminizing surgery. It would be a really expensive endeavor to transplant a uterus into someone from the community, and I just don't think insurance companies are there yet. The next question, will you perform urethral lengthening without a vaginectomy? Yeah, we kind of went over this earlier in talking about both meta and phalloplasty. We can perform urethral lengthening without vaginectomy. I think I'm one of the few surgeons in the world that will do that. A lot of surgeons shy away from it because there's a higher fistula rate. I quoted earlier, we did a study once, and it was about 40% higher fistula rate if you, or sorry, not a 40% higher fistula rate, but the fistula rate was 40% if you did not perform the vaginectomy. And that's, as I talked about earlier, that's just because the anatomic female urethra comes straight down. If you do a urethral lengthening, you extend that, and at that 90-degree turn, there's an increased risk for fistula if you don't do a vaginectomy. If you do a vaginectomy, there's multiple layers of tissue. You can close over that 90-degree turn so that the skin doesn't heal to the urethra, creating a fistula. A fistula is just a hole connecting in our in this scenario, it's a hole connecting the urethra and the skin, a urethro-cutaneous fistula. Let's see. I want to keep my penis but have breasts. Can I do that? Absolutely. I've done that surgery. There are some gender non-conforming patients that say, I should have been born with breasts. I've always wanted breasts. I need to have breasts to help this dysphoria that I'm suffering from. However, I don't want any bottom surgery, and I don't have any problem with that. Can I have a breast augmentation or orchiectomy during the same surgery? Yes, absolutely. We can do breast augmentation with vaginoplasty. We can do breast augmentation with orchiectomy alone. We can do some facial feminizing surgery with vaginoplasty and breast augmentation. I try to keep the total length of time for the surgery less than 5 or 6 hours. And so any scenario of procedures that you want to fit into that your operative time, as long as it's safe, I don't have a problem with it. It would be common for us to do a trach shave, a breast augmentation, and a vaginoplasty all at the same time. I think it would be too much surgery to do a hairline lowering, brow lift, brow shave, rhinoplasty, genioplasty, trach shave, breast augmentation, vaginoplasty. That's too much. We would divide those up into 2 surgeries. The next question. Can I have my nipples completely removed? Yes, I've done this surgery. Some patients say, look, I don't want any nipples. I'm not going to use them. And I say, okay, no problem. Let's not put them on. I've had some patients say, don't put the nipples on because I'm going to get them tattooed. And there are some excellent medical tattoo artists that can make 3D nipple appearing tattoos that look amazing. They look 3-dimensional even though it's 2-dimensional. And patients want to go that route. That's no problem. Whatever you want. Like I said earlier, we can do Christmas trees, Star of David, squares, diamonds, stars, rainbows, horseshoes, frosted Lucky Charms. All right. Next question. Can I get a meta now and get a fallow later? Yes, we do this a lot. There are some patients that just want to stage it for some reason. It's more time away from work. It's more recovery. It's more surgery. It's safe for us to do a phalloplasty before the patient has had any bottom surgery. And it's quite common for us to do that. That's the most common scenario. But if for some reason a patient thought they would be happy with a meta and then they decided they needed phalloplasty, that's no problem. If a patient just, like I said, for some reason wants to stage it, so they sort of have the bottom surgery and then later they come back for the phalloplasty. If it's a radial forearm phalloplasty, then it's just like they're kind of having an arm surgery because they've already had the pelvic surgery. The only word of caution is that a meta scrotum is always smaller than a phalloplasty scrotum. And that's because when performing a meta, I have to save some amount of skin to cover the phallus that I just created. No one wants a skinless phallus so far, in my experience. Versus in a phalloplasty, all the skin is cut for the phallus is coming from somewhere else, the leg or the arm or the back. And so I can take the skin that I would use to cover the phallus and use that to make the scrotum bigger. So phalloplasty scrotums are always bigger than metascrotums. So for someone purposely staging the phalloplasty, I guess I would consider not getting the scrotum done at the time of meta and then save that for the fallow, and then we could probably get the same size scrotum. Another question. If I had a nullo by removing my penis and later want to add a vagina with depth, how do you create the vaginal canal, or is this even possible? This is definitely possible. Normally, I do a penile inversion vaginoplasty where we use the penile skin to create the vagina. However, if a patient has already had the phallus removed, with it the penile skin, then we can do full thickness skin grafts from the abdomen. A patient could have a colon vaginoplasty where we harvest sigmoid and then create a vagina. Both of those are possible. Another question. If I want fallow, but I want to get pregnant in the future, is that possible? Yes. In my practice, we have had a patient that had phalloplasty, kept his vagina, got pregnant, and then gave birth. I think that's pretty cool. I don't know how many times in the world that's happened, but we have had one, and he may have been the first. I don't know. But yes, that's definitely possible. We would just not do a hysterectomy, oophorectomy, and vaginectomy, and perform the phalloplasty. Okay, I think we have another question coming in. Okay, what % of patients wish to proceed with IPP after fallow, and how long do you need to wait? I would say it's about 95% of patients, maybe more, in my experience, want to proceed with IPP after fallow. We like to wait 9 months, or if a patient has had a stricture repair or a fistula repair, I like to wait at least 6 months, 6 to 9 months after that to make sure the urethra's good, and then it's no problem to put in an IPP. That stands for inflatable penile prosthesis. Some patients may want a semi-rigid. Same story. That's okay too. Do we have one more question? No. I think that's it. Well, I really appreciate everyone joining us today for questions on non-binary surgical options. If you have a question but didn't get a chance to post it, just leave it in the comments section and I will answer it later today while quarantined. Be safe, keep breathing, and social distance.